get started. Thank you all for joining. This is going to be a meeting of the OpenOx Collaborative Community Subgroup on Education and Communications. Thank you all for taking the time. The goal for today's meeting is going to be going through the live draft of the living infographic that we have all contributed to. I'll spend a few minutes walking through the version online, and then Leith and Liz will lead a discussion and some feedback so that we can work on finalizing this and starting to disseminate, and also to come up with what other iterations and future plans we want to do for the graphic. So with that, I'm going to go ahead and just for everybody to know, we're going to be recording this. We'll post the recording as usual up onto the collaborative community page. Please stay on mute unless you want to speak, which feel free to do so at any point. One moment as I change my screen here. Okay, so on the OpenOx site, and I put in the chat this link, you can go to the infographic builder. Currently, it is kind of hidden in this submenu right here, but we will put a banner on the homepage announcing that it is now live. So the infographic builder, hopefully it is intuitive, but we do want feedback on how we can make it more intuitive. When you land on the page here for the builder, you'll notice a preview of the infographic that you're building here at the top right. There are some defaults, text and a default image, but everything is customizable. So for example, in step one here, I can change this to best practices for pulse oximetry in Uganda, maybe is what I want to title, or maybe at a facility, at a certain facility. There is a word count limit in here, so you will run against that. But anyways, you can see how you can edit that text. Next up, you can select whatever infographic you want. There are a number to choose from. We're hoping to add more options there and welcome feedback. I know that we have gotten feedback from folks that we have heard and are working on to adjust some of these images to for a variety of reasons, and so we are trying to work on that still. Once I've made these selections, and I'd go to the next step here, and this allows me to start choosing the content for the different tiles. If I choose a tile, it will default to a heading for that, but you can change that heading just by typing in here, and it will change it in the tile up here. Once I choose my first tile and I'm okay with the heading, I can go to the next. Maybe I can't really read this stuff. It is quite small depending on your screen, so you can click the zoom button and see a full-size version of it to see if this is indeed the content that you're looking for. Then I might add that. I'm okay with the title there, and I would keep going through. We do try to have multiple versions of each card, and we'll continue to try and build those out just to have people who look like people from different contexts and from your local setting. So we're trying to work on that. So I make my way through here, choose all of the different graphics that I want on my card. And then once I've done that, the last step is I can drag and drop my logos into these boxes. And when I do that, the logos will appear at the bottom. If I leave them blank, then these will all just appear blank at the end. This could be your organization, this could be your facility, really anything that you want to do there. And then once you're done, hit the generate PDF button. It'll download the PDF, and you can open the PDF, which will be this graphic here. And again, if you did not upload logos, this will be blank in the PDF that you created. Right now, this is only in English, but we hope to translate into other languages. So for those of you who are on the call, if you are interested in being part of that, please reach out. But that is something that we hope to do in the future. So relatively straightforward, hopefully, but would love to open it up for comments. And I see a couple questions in the chat here. The target audience, right now, this is healthcare providers is our target audience. So we do have best practices, some that you can download, pre-made versions that you can download here. These are for healthcare providers. We have gotten feedback that has been well received around creating versions for lay users. Obviously, people on long-term oxygen therapy and many others could potentially benefit, but I think the language would definitely need to change for all of the tiles. And so that is an area that if there's anybody interested in taking that on, we'd be happy to work with you and modifying the content that we already have to make tiles that are appropriate for the lay user, add those into the library, and also create a pre-made card that is for lay users. So with that, maybe I'll turn it over to Liz and Leaf and would welcome additional feedback.
Thanks, Mike. I'm just going to start it off, and please feel free to jump in whenever you're ready. But Sandy, may you please elaborate on what you meant when you said best practices for PulseOx use? Do you think we should adjust the title?
Well, I just like this is really trying to optimize the application of the pulse oximeter and reading it. So it's not best practices necessarily for pulse oximeter, because it's missing a word. It's just, in my humble opinion. So best practices for pulse oximeter use, or how to use your pulse oximeter. You know, just simple, plain language, trying to convey what we're meaning.
It's there now. They added use, looks good.
Yep.
Yeah, and perhaps how to understand the output, because you use a term like interpreting. People are going to, might not understand, but keep it under basic. I think it's understanding output is important, because there's multiple forms of output, such as signal quality and what the values are being displayed. So,
which card is that on, Bob?
I would do it in the same place as you were suggesting best practices.
Well, that was just the title.
It's just the title. There's enough words there already. Can we go to the thing about the reading? There's a card on that.
There you go. Yep.
This one, yeah.
Right. Well, maybe it's understanding SpO2 and other readings, because you're actually looking at more than just SpO2. You're looking at potentially a display of the PPG and understanding what that is supposed to be. It's an optical presentation of the arterial pulse and artifact.
So what are you suggesting, Bob? Give them a concrete thing that we can beat up.
Well, understanding SpO2 and other readings or other displays or other output, because that's what you're really trying to do.
Are you talking about the title for this, Bob?
Exactly.
So, I mean, to address this, I think where we kind of ended up was that everybody's going to kind of want something different. And so we made it where you can just change this. You can make your own title for all of these titles.
So each of the cards, you can change the title?
Yeah.
Yes, it will give you a default, which was kind of the best we could do with wordsmithing. But if you don't like for a reliable reading and you want it to be like SpO2 interpretation, like you can just edit it there and it will appear, when you, and you can see up here, it's changed it so that it will be whatever you want it to be, whatever resonates more with your users. And again, if we have this in multiple languages, that, magnifies this need to be able to modify. So hopefully that can help address some of that, but agree with you.
Can you blow up that card again, please? The other blow up. There you go. When you say manufacturer guidance, what is your expectation under confirmed signal quality by reviewing?
I think the intention there was a comment that was made that signal quality, communication of signal quality good or poor or adequate is different for every device, and that there needs to be some review of the manufacturer's guidance or instructions, or in order to know, because
I would agree with you. That's
it's device
best practice,
specific.
but you don't really expect that to happen, do you?
It won't, right?
So are we just wasting space putting it there, or?
Well, these are best practices, even though we know that.
Okay.
I mean, I
Alright,
hear you. I do
alright.
think I do wonder though. I mean, I think this is an opportunity for communication. I think users make the assumption that devices will communicate to them in an intuitive way if it has poor signal quality by flashing some sort of low signal error thing, you know, and not all devices do that in a way that's intuitive. And the only way to know is to read the manufacturer's instructions.
Yeah.
The solution is the manufacturers need to do better on this. This isn't going to fix that, but we do need to communicate to clinicians that don't assume that just because the device isn't alarming, that it's really happy with the signal it's getting.
Mhm.
I mean, maybe we phrase it like that. Maybe we phrase it even more directly.
You raised an interesting question. Do all devices have alarms? Certainly the finger probes don't, finger clips don't.
No, but they have
Yeah, I mean,
of quality off time still, Sandy, as you know.
Yeah. Well, I mean, Mike raised the specter of alarms, and I don't know what the expectation is that clinicians using these things might think there is an alarm. And maybe they should be alerted to the fact that there might not be.
For the
I
signal
think that's a good
quality
point.
indicator, could you just say, signal quality indicator is device specific, check manufacturer guidance, and put it all in one sentence?
Well, I think you could probably promote manufacturer guidance higher, because everything you do with the device, you should check the manufacturer guidance. Right? I mean, what kind of fingers you put it on, how tightly you put it on, all the contraindications that are listed in the guidance.
Could we expand? So what if we delete first bullet that's manufacturer guidance, and then the third bullet here, signal quality indicator, we say device specific, but maybe just expand that into more words that communicate more clearly that each device has a different way that this is communicated.
You have a lot of space at the bottom. You might take out manufacturer guidance, and at the very bottom, after it says ensure proper probe, you can say, always check with manufacturer guidance, for specific instructions or something like that.
Okay. All right. Noted. I can work on that.
And I would include prior to use, because everyone needs to be familiarized if they aren't using it frequently. And all of those issues Sandy raised and many others are contained in the IFU.
So you'd put it at the top. You'd have it the first dot point. First thing you do is read the instructions.
Absolutely.
Well, that's what you're supposed to do. But like all good engineers, you probably, if in doubt, then you read the manual.
Only clinicians read manuals, Sandy. Your PhD is in physics, so yeah.
I understand.
Robin's asking too. Sometimes that information is missing. Like they don't. Yeah.
Well, that's a problem.
But Mike, you've been including some of that information on OpenOx. Is that? I know it's difficult to get it from everyone, but they should have that available even on a QR code.
Yeah, we did present to this group a QR code that's intended to be a sticker that could go on devices that links to the OpenOx site. For devices that we're testing, we can link to their manuals. So sort of indirectly, we could have a general QR code that takes users to a site where they can look up the device and try and find the manual. Still a lot of steps, but
what does it say in the standard? Does the standard tell us that we have to have a link to the QR code?
Not it's suggested, Sandy. It's not a requirement. It's an option that can be done. But if they wish to print it or include it on the device physically, that's their choice.
I believe there is some litigation happening in California to require distributors and maybe some manufacturers to add product labeling to make it easier for users to get access to some of this information. It's specific to the issue of skin pigment and performance, but that's evolving. I mentioned it as an FYI, but there is a legal push to try and make this, and that is for direct to consumer devices.
Okay, so not necessarily medical devices.
No, but yes,
No,
Bob, we could put the manuals on OpenOx for, devices. We could explore creating a repository, although we don't want to become a clearinghouse.
FDA tried to do that a number of years ago. Just FYI.
Yeah.
I don't think, I mean, I think it's hard to maintain.
Keep them up to date, wouldn't you, as well?
Yeah.
I mean, the other thing that I could propose to do, we could go through and try and review the different, I mean, there's a relatively finite number of examples. You're talking about probably like 10, if I had to guess. We could try to characterize them. I feel like that would be an overwhelming tile.
Yeah, I
If
think
we were to give examples of these are the ways, it's just so specific.
Yeah, and each manufacturer tackles the PPG output for signal quality differently, both in a metric as well as in a bar display.
Can the standard modify its language? I think I provided this feedback already, but can the standard modify its language to require user testing of what is considered to be an intuitive alarm for inadequate signal?
Oh, wow. Slow that down.
Right now in the standard, there is something in there that says something along the lines of, the device needs to communicate if it has a poor signal. But can it require actual, right now, I believe it's just at the discretion of the engineer for that device.
Are you asking about whether the alarm signals are effective at communicating and functioning as a risk control measure?
Yes, but specific to signal quality.
Well, so all alarms are supposed to be, quote, and I use this term, validated.
Right.
But
is signal quality alarm signal quality falls into that?
It will now.
Yes. All communication to the user, signal quality is a form of alerting the user of a hazardous situation. And that's basically the definition of an alarm. And so the manufacturer is obligated to, if you will, verify that because alarms are risk control measures, right? They're designed to prevent something bad from happening. Manufacturers are obligated to verify that their risk control measures actually work. They can't just dream one up and then pretend that it's good. They have to go out and test the user interface aspect.
Exactly.
The degree to which they do that might be questionable, but they're supposed to.
And Mike, that has to be done on someone who is a first-time user of the product. So you actually bring clinicians, or what would be intended as an end user, in to look at your monitor and try it and make sure that they understand its operation, correctly understand its operation without assistance. And if they need assistance, then you're supposed to correct whatever the output is, be it written or otherwise, so that they will understand how to better operate it or appropriately.
So, I know this is a bit tangential, but so in theory, if a group of experts such as this were to review signal quality alarms and determine that they are inadequate for different devices, then that would put the onus on the manufacturers to come up with something better.
Absolutely.
Because it would then invalidate their meeting conformity with the standard.
Absolutely. They should immediately write an article, a scientific article that says, we tested these alarms and found that they don't actually do anything.
Yeah. I kind of wonder, I wonder if that's obviously a longer term solution, but I do wonder if that is something that this group could potentially weigh in on. In a 1-hour session, we could rapidly go through the signal quality, low perfusion indicators for a handful of devices that represent the types of indicators that are used by different manufacturers and demonstrate that they're inadequate as a first step. And then, potentially we could, and just write that up. That would be very easy as a perspective
So if
piece.
you're going to do that, I would recommend you get a human factors expert, alarm system expert, to walk you through, because just because you have a group of clinicians sitting around the table reviewing it is not the same as the actual bench testing of systems.
I was just going to say the
Understood.
same
I
thing.
think there's value in both, but I
Yeah.
also would argue that what we have right now, which is not working, was largely the group that you're proposing, is my guess.
Yeah.
Well,
And that's so I think there is more value in having, lay clinicians, so to speak, but also even people with expertise in pulse oximetry who are also kind of in agreement that this is just not working.
I think this is very worthwhile. I think we're getting off topic, and I'm happy
Yep, sorry.
to continue this. No, it's a great topic, and I'm fully invested in it. Because the standard is the repository for where those great and wonderful things should be.
and likewise, until we finish the version that's under consideration in April, it has not existed before as a requirement, and we now have it that for the validation of that clinical testing that needs to be done. So anything that could be done in advance of April, we will certainly consider it in bolstering that requirement.
I don't think anything's going to happen that quickly, because that you're talking about we'll talk about it later.
We need to get some others in. There's Kumadini has a hand raised.
Oh, thank you so much for letting me talk. So, hi guys. I just came in to the conversation, but I just wanted to point out about if clinicians experience any problems, especially any type of adverse event or inability to pick up pulse oximeter readings on time, we do have a system to report that. Please do consider dropping, reports on the MDR, and I'll drop a link to that. Thank you.
Great. But for the purposes of this page in front of us, the reliable SPO2, what would you think about like a bot? We've got room at the bottom to do a box at the bottom that says something like, please ensure you always read the manufacturer's guidance before you use the device. If you full stop, if you do not have that information, could we do a QR code that links back to the OpenO2, and you have there whatever information you do have, whatever manuals you do have, they can check and see if it's there?
Blended, yeah, use that space to really hallmark that it's the manufacturer that's responsible for providing the user with knowing how to operate, not this very helpful infographic. Ultimately, it's their responsibility.
I would take out the word please. I would just say always check manufacturer guidance for proper use of the equipment.
And if you put it in a box, it'll stand out. You make a big board around it or something, it'll jump out. Is that okay, Mike? Does it sound okay?
Yeah, sounds great. Just taking notes.
Okay. And I think there was a question we didn't get to from David up above a little bit. Did you want to talk about that, David?
Sure, yeah. Yeah, mostly just wondering, I know on our devices, we have Masimo devices, if you tap on the waveform or somewhere around there, you can see the perfusion index, which sometimes is just a nice way to have a numerical representation of how good your signal quality is. I don't know if all devices do that, but anecdotally, most people, I think, don't know that you can do that on our devices. So I don't know if that would be useful to mention that some devices allow that. The tough thing is just that probably every device does it differently.
David, where are you based? Sorry, do you mind just a one-liner of your background?
Oh, sure. Yeah. I'm a hospitalist at the University of Wisconsin.
Got it. Thanks.
Okay. So, and do you want to zoom back out to the whole thing again, Mike? So I guess the question before us, we're at half time, is this has been through an extensive editing process, as everyone will recall, and it is dynamic, so we can always update it. But I think the question before us is there anything on here that you really feel has to be changed in addition to what you've already shared before this goes out into the public arena?
Well, I think it looks great.
Do you think the instructions are easy enough? I think it's beautifully simple. Mike does a great job of making these things really easy to understand how to build it. And then, Mike, if you don't want to build it, if you look at the like a lot of people, it's like, no, we don't no time for that. We just want to download a pre-made. You've got that, right? Yeah.
Correct. At the bottom here, and hopefully soon we'll add one that's more specific to neonates. If anybody's interested, and Mark has provided a ton of feedback on that already. Very
Mike,
appreciative.
sorry,
But
can you go back to how to place the probe?
Yeah, I was
Okay.
highlighting that because there were a bunch of changes on here in the
Do
last
people
round
know
of
what
edits.
transmission means? I mean, is the ordinary clinician going to know transmission is, like a finger clip,
I thought there was a definitional slide where these terms were explained. Yeah, this one. Yeah.
Okay, good.
That's clear. That's very clear.
Do you?
So but you have to is this one of the required cards? Because if you don't put this card on your deck, then people aren't going to know what that means, are they?
Well, you'll figure that
Correct.
figure that out yourself, right? Whether you need to explain that, how sophisticated your target audience is, whether you need it or
Okay,
not.
I got you.
Did you guys
Good.
have a conversation about whether you should put a link to how to report any kind of inaccurate device from the infograph there?
That's a great idea, Kumo. Maybe like
Yeah,
What are you gonna put
would
there?
report, adverse events or medical device related adverse events to, I can get you the language for it.
Well, in the US, we know who, but this
Where
is
do they report to? Like in Uganda or Zimbabwe?
Well, can we say just to the appropriate, hospital or clinical responsible party or something like that?
Yeah, because you can't link it to the mod database. It's
You could, but
yeah, but it's not. But people outside of the country cannot contribute.
no, I think they can. Kumu, do you know anybody can put in MDR?
I don't think so, Sandy. I'll check
No.
up on that, but I think Bob is right.
That was my prior understanding when it came to mechanical ventilators.
I think our template probably will not take that in, when you're reporting. I have never reported full transparency on the mod database as a clinician, but I believe it asks you questions so that it kind of leaves out outside US. Okay, sorry about that. Let me rethink that.
That said, it is certainly the case that a hospital has a reporting structure for adverse events. What they do with it is, they're supposed to investigate. It's part of their quality, oversight.
Maybe I'm gonna jump topics where it says how to place the probe. You draw a nice red bandage, but in the two cartoons above it, you have a little X. So I'm thinking a big red X over that instead of the right, because that, I've seen red bandages.
Yeah, that's
nice.
Nice. Yeah, that's nice.
Sounds good.
And you could even, if you've got you might show light squeaking out. If you have put the whole, I'm just playing with ideas here. If you put the whole, the problem is if the emitters are not seated well against the finger, the light squeaks out the sides and pipes around, does all kinds of crazy stuff. So if you could kind of maybe lift the top
Good idea.
and show some light squeaking out, some red light squeaking out, then people will say, oh, let me look for that.
Or
Sounds good.
light squeaking in. I mean, in the end, ambient interference is huge in sunlight.
Yeah.
I can modify that. Thanks for that. That's a great point.
And a tick on the green as well.
Yeah, perfect. Good idea.
And so you're not supposed to take a finger probe and open it up and use it on the forehead. But that's pretty common, isn't it?
Yeah. Or put it on the ear. I guess that would be the other thing we were playing around with, was showing the disposable finger adhesive kind of rigged to be on the ear, which is also common.
Mike, remember that report for pediatric use where they used an oral airway, and this was published in ANA just last.
Yeah.
And they wrapped a finger probe on the end of an oral airway and stuck it in a child. I mean, that is so off-label and should never be allowed to be published. And there was no even comment from the editor about it.
Did it work?
Yeah, but did it work? It gave a value, Sid.
Nobody knows.
It gave a value, and nobody correlated it to an arterial stick.
Oh, maybe they're looking for trends. Anyway, I digress.
We'll test that out and get back to you on it.
All right.
Liz, can we go back to this reporting thing? Liz has a comment in the chat too. This is really important. And I'm wondering whether something general, as she suggests, reporting to the appropriate authority, because in many of the hospitals where we have activities, our members have activities, there isn't a culture of reporting adverse events or faulty medical devices because nothing happens. But you want to change that. You want to build a culture where the clinicians, report these things. So, or the engineers to the highest authority in the facility. So something that encourages that, a culture of reporting up, even if it's a sentence.
That's exactly what I think. And I guess for every hospital, different countries, it will look different. I'm not sure whether just the infographic will change everything in the culture, but I think it's a good place to start.
We could say, send your comments to Mike Lipnick.
With his email.
Yeah,
well, maybe
I'll give my cell phone. I'll just put my cell phone number on there. Make it easier.
Well, but you could put a mailbox in openox.org that says problems or concerns at openox.org.
I mean, the liability for trying to cover a box like that, I can't even begin to fathom how we would address that.
No, you want them to put it up to their own authorities.
Yeah.
Pressure on the hospital to pay more attention.
I mean, the unfortunate reality, my reaction to that is I think most users just are not going to know when they're having a problem with pulse oximetry where it's leading to an outcome problem. I think that's sort of like the fundamental issue here. People just don't realize when it's a bad signal and giving an unreliable reading, or the probe's placed incorrectly, or the device is just really a crappy device and they don't have blood gas. Like there is no easy way to recognize when the failure is because of a failure of the pulse oximeter.
But Mike,
So I'm
you
not
may have to go through like 4 or 5 probes just to get like I'm talking about my experience when I was at a smaller hospital where they decided to take reprocessing into their own hands, into the hospital system's hands. And unbeknownst to us, they were just sort of cleaning up the adhesives and re-sticking back the LED sensors and emitters and giving it back to us, especially on pediatric sensors. And it was not uncommon for us to induce a kid and, you put on the pulse ox right after. Usually the kids are not going to tolerate having a pulse ox put on them while they're awake. And we would go through 4 or 5 of them. And so, like those kind of signals would be important, I think the average clinician is going to fiddle around with it, reposition it, do all these kind of things. But I think they'll have a threshold where they'll be like, okay, we need to report this up,
Well, the hospital is a manufacturer then, if they're doing that, you know the rules, but That's crazy.
I mean, that makes
know.
me think maybe we should add somewhere explicitly here, do not reuse disposable probes.
Single use. Right, because you can take the problem is if you're on one patient and you go from one side of the body to the other side of the body, they can interpret that as one use. So that usually there's a number 2 with a line through it, right? Don't use it on more than one patient.
Single patient use, yeah.
But yes, Mike, you're
Say that phrasing one more time.
Let me get the exact words. So I
I think
screw
it's
it up.
single patient use.
Thanks, Luis.
I suggest including the symbol, which is an international signal for do not use on more than one patient.
What do you mean by international symbol?
Well, it's the 1 with an X through it, a 2 with an X.
I'm looking for it. I'll see if I can find it.
But yeah, it's it's an ISO IEC symbol.
Okay.
An ISO symbol, yeah. And it got pulled out of our standard because it's now in the general. All right, I'll have to track it down.
There's just a question from Raphael in the chat. I'm not sure what he's referring to. The airway pulse oximeter publication.
I think what Bob was alluding to.
Exactly, ANA last year, and it's one that I shared when we were together at one of our earlier OpenOx meetings at UCSF. So I can share the link.
Right.
I shouldn't share the publication because that, for copyright reasons. But I'll send it to Mike. I can send it to you and you can put it in, I think.
Yeah, please copy me and Fifi and we will put it in the follow-up email.
Thank you. But I just want to emphasize that publication does not say anything about off-label use. The editors of the journal don't say anything about that, but it clearly is inappropriate to be using a device unintended for immersive fluid, direct fluid contact into an oral airway. I mean, there are a lot of complications to the whole write-up, but it was done and it's reported, and I just think that that's a bad thing to do.
So there's the symbol. So if people can understand, that means don't use it on 2 people. How would you know that?
So there is a single use logo. That's a single use and a single patient use.
Oh, okay.
There's 2.
Okay. I think just the words are going to be clearer.
I'll try and come up with something based on what you guys have provided.
Hey, this is Rich. I appreciate Bob's concern, but clinicians use things all the times off-label because we're not manufacturers and we can use things off-label. And, I'm not advocating for it. I just, my favorite example is I worked with a trauma surgeon. He used to put a water weenie through gunshot holes in the liver to tamponade the bleeding. We'd have them sterilized ahead of time, which is a child's toy that as you grab it, it just keeps going over on itself. So I agree. I think that publication was very odd, but at the bedside, the average clinician is not thinking about reporting something on the MAUDE database or is the device off label. And Mike and I have had the discussion. I see patients come out of the OR with a finger probe taped to their forehead. And because they're getting a signal, everybody assumes that it works.
There's a little exchange in the chat between Mike and Kumudini. Do you want to just talk about that? What do you mean a global entity?
So, you know how the FDA the whole purpose of MDRs is to receive signals and analyze them. So whatever it is, it's not working, you know, on darkly pigmented folks, it's not working, you know, to output when the perfusion's low. So that's what I mean by signals, nothing extraordinary.
Sorry, I'm thinking like raw signal waveforms.
Oh, yeah,
That's
yeah,
where my
sorry
brain goes
about
sometimes. That's okay.
Sorry.
That makes sense. Thanks for that. I'll have to think about it a little bit more.
So we've got 15 minutes left. Shall we pivot to dissemination, testing? So I guess this doesn't have any impact at all unless we see it in use on the walls of primary healthcare centres, ICUs, hospitals, everything in many, many countries. It's available in English first, so that will limit to some extent where this is tested. But I think we should have a discussion on how we disseminate this, and people will have different views. Whether we officially say it's out for testing and we target, 10 facilities in 10 different countries to test it, that just invite them, if you like, to be part of a testing group where they go online and they either make their own or download whatever they want, get it up and out in their facility in whichever way they would like to, and then sort of report back to us on the whole process a month later. Or maybe there's other ideas people have. How formally we kind of want to do this next phase, or if we just let it rip, we just have a big event where we announce it. World Pneumonia Day is coming up on November 12th. There's numerous conferences that you're all aware of where this would fit. Whether you just announce it and launch it into the public arena in a big way and let 1,000 flowers bloom, see what happens.
Could you consider like platforms, like clinical spaces where it's acute versus a little bit more stable? What I mean by that is like in a chaotic emergency room versus, you know, a step down unit, and basically see if those who are actually able to read it and apply it and have time to do this, whether it makes a difference, because I think the messaging is important from those folks to those who don't have time, like in the emergency room or in a ICU that's really busy, to adopt, you know? I'm just thinking.
I am certainly in favor of launching this sooner than later. Having people know they can customize, I'll bet you in that process, they will realize, aha, this needs to be improved. And the sooner we get it out there as a test balloon, at least, the more likely it's going to get refined.
It depends how controlled you want to make it. You can see how you could construct a group of, let's say, 20 different facilities in a broad selection of countries and different levels, ICU, et cetera, right down. And you could identify individuals. We all have these networks. We could come together and agree that list of 20 facilities and then have a process where they're formally invited. There's sort of a procedure that we all ask them to go through. There's a report back. We use something really simple for them to give feedback, like a Google form or something that doesn't take too much time to get their feedback. And that would be like a soft launch of the thing. We could still announce it publicly and announce this soft launch and then make some tweaks and changes on that feedback and then do a big launch early 2025. We could do the soft launch before the end of this year, early 2025, come out with a much bigger launch. Because we'd have this group now of 20, hopefully champions, 20 facility champions that could help us launch it as well. So Liz agrees with soft and then big.
Liz, I think for me, my question would just be what, I don't want to say what kind of feedback would we be looking for, but how to measure whether this is working or not. Just because it's an infographic and, we could put it on the wall, but it being on the wall versus it being used are two different things. So in terms of what the metric for quote unquote success is, would be something that I think we'd have to think about a little more.
Okay, agree. Jeff, I think, sorry, we missed someone there. Jeff, your hand is up. I can't see that for some reason. Go, Jeff.
Yeah, thank you. I'm here in part because of my role with the Anesthesia Patient Safety Foundation, and we're very interested in helping to promote the infographic. I've done some work with Michael over the last few months, and he and Daryl have contributed an article for the STA news or the APSF newsletter that'll be published in February in 9 languages, including English. And we have a pretty wide distribution. I recognize that it's anesthesia focused, our communications, but we could always tailor that to encourage people to spread this information around the hospital when they read about it. We have a social media group at APSF that can amplify these messages, and I was planning to have them do that when the article comes out in February, but we could do something sooner if you think it would be impactful. And there's more opportunities through the APSF communication channels if people are interested.
Jeff, I was going to mention Steve Greenberg because I've worked with him so much on that APSF side. So it's a great way, and it stresses safety. And that's what this whole thing is about.
Can I suggest a process for us, which has worked with other initiatives like this that I've worked on? If we create a Google Sheet with a set of countries, because we have to have, the purpose of this is global, with a set of countries, the US will be one of them, but there'll be others. And then you can drop into that Google Sheet. If you have an idea like ATS would be a great partner group to get this out and about, and you have even a name and an email of the person at that institution that could help us. If we can populate that collectively, then we can huddle around that and come up with a sort of a short list, come back to you and say, okay, this is our sort of testing group, and get agreement on that, and then go out and ask them, invite them to participate. But it'd be nice to sort of source that list from this group.
APSF is definitely one. And they are well represented internationally. As a matter of fact, as Jeff pointed out, it's translated, and the Japanese use it heavily. I've seen it in the OR lounges.
Can I suggest that if you are thinking of a soft launch before a big launch, that you consider the OR space with anesthesiologists as guardians of this? Because I think one, we're hands-on, and two, we're always by the bedside in the OR. And I think you will probably get good feedback. And if you can make a delta difference among anesthesiologists in the placement and the performance of pulse oximeters, you will certainly have that in other spaces.
Right, I think Mike's just put WFSA and others in. So yeah, we'll add those to the list. And once again, we're going to need names and emails of suggested individuals, because we'll be reaching out to individuals and sort of asking them to get their institution on board with testing this thing.
One specific group that might be helpful, and we do have representation from them in APSF, is the Association of Peri-Anesthesia Nurses. We have their president as a member of our board, and that would probably be a great society to help promote this and get feedback through. I can make that connection if you're interested.
Great. We're going to ask you to put all this into a Google Sheet. I think after this call, we'll send that around.
That's
and
a good,
Mike,
yeah, that's a good point, Jeff, because a lot of pulse oximeters get placed by the nurses preoperatively.
Right. I'm not sure we picked up. There's a point here from Alexandra, not on this issue, but going back to some things we discussed earlier. Did you just want to voice that over, Alexandra, and make sure we picked it up?
Oh, yeah, thank you. I just in the infographic wanted to make sure that I see some things about it in the cards. I was a little late. So Yeah, this is great. I think this is helpful. Just to introduce a little bit of that skepticism on the numeric values. I think we're just having issues with that.
You might want to make the third bullet the first bullet to make that the prime point. Typical accuracies are plus or minus 3%.
That's just
Sounds
one
good.
standard
Yeah.
deviation, right? So are you, do you specify what that plus or minus 3% is?
Yeah, our testing actually found it was plus or minus 5%.
Are you talking about you're talking about, yeah, this is a complex,
Yeah.
Yeah, you're talking about
drilling
you
it
have
down to a plus
specify your
minus number
confidence
is
interval, but I think the
challenging.
intention here is just to indicate that these are not perfect devices.
Right.
Okay.
I mean, this doesn't have a confidence interval associated with it or anything like that, but I think that goes over the head of most of the people using it.
I mean, we can certainly change it to like plus minus 3% or more. The reason we did 3% here was, yeah, there's disagreement still about like if you're getting to like the statistical analysis, like the distribution of the data, what like it's not normally distributed, and is the I don't know. If you have suggestions, we're open to it. I think the key point here was just communicating, as you said, Alex, that there is error inherent to these, but open to input.
Yeah, with the current guidance as is, I think just like making sure that people understand there is error to consider is the bigger message. I just worry if we put something like plus or minus 3%, it may, folks will look at that and say, oh, I've got 97, so it's between 94 and 100, and be very concrete about that. So that's the only caution I have.
Well, yeah, but that's better than I'm thinking that it's 97 spot on.
I mean, we could remove, this is a question for, ISO FDA. We can remove the ISO and FDA compliance piece and just say devices commonly are plus minus 3 to 5% of the actual value.
Well,
I mean, we can.
You don't mention ISO in here at all, do you?
In the top right below the circle.
Oh, ISO and FDA.
Yeah, I think I would vote for that, Mike. I don't know what others think, only because, it's safer to communicate that the error is uncertain for a given patient, and that whole ARMS less than 3%, I think is so confusing to the average person.
Totally.
And it's not
So maybe we just change this to say many devices are plus minus 3 to 5% of the actual SpO2 value.
Well, all devices have an uncertainty. And
yeah,
that arguably that uncertainty is at least 2%. And I was gonna say the less money you pay, the wider that gets, but that's not true either. Right? Some devices can have 3, 4, as 5%. So all devices have uncertainty associated with them, which is why we get into this mess.
Well, and sometimes you purposely pick a device for other aspects, knowing that you're only going to use it for trending, and you're accepting of that degraded accuracy because you know what it is.
Sounds good. I'll make those edits. I've been taking notes.
Okay. Just got 4 minutes left. Can I just summarize where I think we got to, Mike? Hand back to you and Liz.
Sounds good. Wrap up. Yeah, sounds good.
Yeah. Just a minute or two. So this looks fantastic. Mike's going to make the few tweaks that you recommended, but this is it's always meant to be a dynamic document, so no one should ever think it's set in stone. We'll make those changes, and then you're going to get a Google sheet to help us populate a universe of potential partners to help with a soft launch. And that soft launch would get going before the end of this year. Won't be concluded, but we want to reach out and have maybe 20 facilities or institutions using this, testing this. We want a geographic spread and a, let's say, health facility level type spread. We'll be limited to English speaking countries, so that limits us a little bit, but it's still okay. And then once you populate that, we'll put our heads together and come up with a short list and then get back out to you for a sort of final review. And then an email, formal sort of invite will go out from Mike's team to invite them to participate. And although we can't, it's not a proper study, so the only kind of feedback will be clear on the feedback we're looking for. It'll be ease of use, hospital support. We'll come up with a few indicators, but this is not a scientific assessment of impact on, and we can't do that. And then we'll use that information we get to tweak a little bit further if we need to, and then do a proper hard launch in 2025. There's lots of opportunities. The Lancet Oxygen Commission's reporting in early 2025. There's a huge amount of recommendations around pulse ox use. You could sync this infographic hard launch with that, but there's many others as well. So I think that's where we got to from my perspective, but back over to Liz and Mike.
Thanks, Liz. Any comments from you?
So can I just confirm? So you want details of anyone you think it would be useful to include in a soft launch? Do you know when you'd need that by? And also, in terms of what we're asking from those people that we would be putting forward a name of, what would we be asking of them? Just a general. What would you be asking of them?
Yeah,
just
you won't be asking anything of them. These are ideas.
Sorry.
And we'll take care of that. Yeah, just people whose institution, first of all, people who might be individually very interested in testing this infographic in their institution or in institutions that they have a sort of connection to if they're a member of a society. You would just name an email and we'll do the outreach.
Okay.
Thanks, Louise. Liz, any comments as we wrap up?
No, I had nothing else to add apart from one thing. From the discussion here, a lot of suggestions are based on a system that works as well as it should work. But I believe we would like to maybe have an iteration of something that would be in a system where we don't have all the systems we want in place, or maybe have systems that are work in progress. So my inclination would be to have, I don't want to say more generic, but probably a bit more general information on the infographics as opposed to, specifics based on that. But otherwise, I just wanted to say thank you to everyone for bringing it this far, and it's exciting to see where it's going. So over to you, Mike.
Thanks, Liz. Completely agree. I want to echo Liz's thanks to everyone for all their input so far. We're almost there with this. I'll make those edits and get an email out and follow up with everything. Thanks again to Leith and Liz for co-chairing this, and thank you all for your time. Look forward to talking again soon. Have a great day, evening, everyone.
Thank you for your efforts. Thanks. Bye.